Welcome to Arizona. I see that everybody got the memo, no ties. I debated even wearing this jacket today, but I figured I ought to be at least a little bit respectable this morning. But I'm delighted to be here. We're in a county of 4.5 million, over 4.5 million people, and it still has the distinction of being one of the fastest growing counties in America. And of course, what comes with that is a lot of opportunity and a lot of challenge. And I'm here this morning to really tell a very broad story. This story is condensed way down. There are many stories together in this. The facilities piece of it is one portion. It's an important part of our story. But in many ways, this is a story about the resiliency of the American healthcare worker. It's about the creation of a new American public hospital system, a safety net system of care for a large population of underserved patients. And so it's about how we approached our challenges at Valleywise Health, formerly known as Maricopa Integrated Health System years ago. And before that, it was Maricopa County General Hospital. We've been known by lots of different names. So it's a broad story, and I'm certainly happy to answer some questions at the end if you're interested in any small part of a larger story. So I've been fond of coining this term, this is not your grandfather's county hospital anymore, because literally we started with a facility that was planned in the 60s, finally built in the early 70s, and we had outpatient clinics, community health centers. They're all federally qualified health centers throughout Maricopa County that were sort of afterthoughts whenever there was a division of motor vehicle office that vacated or whatever. Somebody at the county at the time says, let's go put a clinic in there. And of course, for you facilities folks, darn well that the patient flow doesn't work really well in a DMV office. But that's what we were dealing with, in terms of the reinvention, literally the reinvention from top to bottom of a safety net system of care. So let me just jump right into it. I always like to start with our mission, and you do too, in your organizations. And we'll talk a little bit about this, but it's very simple, to the point. Even I can remember it. And so it's important in terms of our culture that we'll talk about in a second. So a little bit about who we are. I mean, we've been around a long time. We were established in 1877. And so for you history buffs out there, when did Arizona become a state? We were the 48th state, 1912. Okay, so what were we doing out here before Arizona was a state? Well, of course, we were part of the Arizona Territory. And we were created because there was a need. There was a need, a place for people to go that we didn't know how to take care of. We didn't know anything about their diseases. They had communicable illnesses. They had mental health problems. And the names for hospitals back in those days were awful. Sanitariums, pest houses. Yes, they actually called them pest houses or houses of pestilence. So that's how we were created, but it was in response to a need in the territory, at the time. So, today, obviously we've grown, with the times, and we were part of county government for a long time. Matter of fact, we were split away from the county in 2004, through a voter referendum that created an independent special healthcare district. Now, we're still public. I have an elected board. I have five members of my board that are elected officials, and they're elected by the voters of Maricopa County. But we're not part of county government, and that's a whole other story in terms of the rationale for spinning that off, from the county. A significant thing happened in 2014, and that's when we presented to the voters Proposition 480, and it overwhelmingly passed. And that's another story in and of itself, but I'm going to reference it, several times in the presentation. So I've been here it'll be 11 years in September. I can't believe it. Time flies when you're having fun. But I got here in 2013, and the board had several things, for me to do. Number one, we needed to reinvent our health system. We needed to rebrand. We needed to get our financial problems under control, which were significant, at the time. And I said, yeah, okay, no problem. I honestly underestimated the financial perils that we were in 2013, and so we'll talk a little bit about that. Okay, so here's where we're located in Maricopa County. This is a little bit about who we are. The Arizona Burn Center is the second largest burn program in the United States, and I'm not biased or anything, but it is the best, most comprehensive burn program. And if you say that's in the United States, then it's in the world. Okay, so it's home to that. We were the first level 1 trauma center here in Maricopa County, actually in Arizona, back in the 70s. Now I think there's 8 level 1 trauma programs, here in Maricopa County. We have a very heavy footprint in behavioral health care. We have 422 inpatient beds for behavioral health care. Most of them are in voluntary or court-ordered evaluations. And of course, we have a broad footprint of community health centers across Maricopa County. And of course, we have 2 emergency departments, one located downtown and another in a very unique facility that we purchased from Tenet Corporation and converted it into a behavioral health facility, but we kept the emergency department, full service emergency department, open because that community was underserved. And there were over 40,000 visits each year for people in that underserved community that, I shudder to think, what would have happened had that emergency department closed. This is a little bit better representation, of where we're located. And when we planned, just to give a little bit of a sense as to how we approach our planning, when we planned our new facilities, our new federally qualified health centers, the planning metric that we selected was not where do the paying population, where do they reside? Can we make a go of it in those communities? Look, I've always been taught no money, no mission. I was in Catholic healthcare for quite a while. The nuns would come into my office and they'd say, now remember, Steve, no money, no mission. So I got it. The difference is that we go to where the need is. And then we try like crazy, to figure out a way to cobble the resources that we need in order to make a go of it out there to take care of community needs. And that includes social determinants of health and not just clinical care and the needs of the individual patients, but populations, of patients. So the planning metric that we used was where does the Medicaid population reside, and we use the Medicaid population as a proxy for vulnerable patients in our community because that's where we could get good data. And we wanted a facility within about a 15% travel time to 95% of the vulnerable populations in Maricopa County. So a little bit about that. You can see we are a poster child for a safety net hospital system. Clearly, almost half of our patients and almost half of our revenue is with Medicaid, state Medicaid agency called Access here. Very small commercial insurance percentage. Medicare, pretty small as hospitals go. And then, of course, a large share, and that uninsured, that's about, that's a little dated now. We're almost 20% uninsured now. And a lot of that had to do with Medicaid redeterminations that, some folks didn't qualify anymore and went uninsured. And that had to do, as with the pandemic. Pandemic is something that figured very significantly into the reinvention of our health system, and we'll talk about that. And then other government, these are other kinds of government programs that we participate in. This is the diversity, the ethnicity of our patients, and clearly you can see well over half are Hispanic, the Latino population, and of course, our care and our makeup of our population, our employee body actually follows pretty closely behind that. Okay, so just to put this into perspective, we were planning not just a new hospital, but our entire delivery system, which includes the clinics, the behavioral health services, and our acute care hospital, which, as I indicated, was outdated. And so it was a pretty big deal in terms of a sell to the community. I mean, it's no secret that Arizona is a fairly conservative state. It's become a little bit more purple, especially here in Maricopa County. But at the end of the day, I mean, don't touch a penny of my property taxes. Okay, that's the predominant, attitude of pockets of population, and that's fine. But this project, because obviously we don't have strategic capital to spend because our margins aren't adequate in order to go out and to the revenue bond market and even get a decent bond rating to repay the debt. So that's why we're a public healthcare system, and that's why we're supported by a very small tax levy for our maintenance and operations. So we rely on the generosity of the public for our strategic capital. So we had to approach this to make sure that what our message resonated, with the public. And so we kept it very simple. Safety net services, teaching. We have an extraordinary clinical learning environment, and we're the largest single residency program here in Maricopa County. And that resonated with the public. And in expansion of our care for behavioral health patients, mental health care in our community. And when I got here, I said, well, but we gotta talk about why we deserve the tax support, and how that lessens the burden ultimately on uninsured patients, and it's all this stuff. And they said, no, Steve, their eyes are just going to glaze over it. So keep the message very, very simple. And what we couldn't say at the time was that we came into a situation where we were bleeding red ink. I got to tell you, nothing focuses the mind like you missing payroll, right? And so the story was very challenging because, I mean, imagine me saying, well, we want $1 billion of your tax support to support the reinvention of this essential community healthcare system. We're not sure whether we're going to be able to staff our new facilities or operate the new facilities, but we want your money. That boat doesn't float, right? So we had to be very careful about the message. These were the headlines, in 15. So I got there in 13. We were planning the messaging for the campaign. It passed in 2014, in November of 14, overwhelmingly 63 to 37%. That's a landslide for you political junkies out there in polling jargon. And it passed in every single legislative district. We had broad support from the business community, from a lot of community groups, certainly grassroots. There was a small group, a group of legislators, very conservative, that felt like it was a blank check for us and they opposed it. But guess what? It passed in every single one of their districts by a wide margin. So it was very satisfying. But then the day after it passed, and I remember, and we were watching it with my team, the polling results come in, and after about 10 minutes, it was over. We had won. And so I'll never forget that day. But then after that, okay, back to reality. And so I got my team off site, and that's when we started having the hard decisions, hard discussions about what were we going to do to turn our finances around. How were we going to approach that? So this is what I showed them. Like I said, nothing focuses the mind like missing payroll. So this was, in 14, late 14, we showed them that if nothing changed, if we kept on this path, you see where that line dips below 0? That was August of 15. And this was the end of calendar year 14. We didn't have a lot of time to mess around. I didn't have time to hire, a Big 8 accounting firm and have them come in, spend $1 million with them to give us a report that's that thick, to tell us what we already knew about our organization, and then want to charge us another $1 million to help us implement the changes. We didn't have time for that. I called my friend Chip Caldwell, and we talked a little bit about the approach that we were going to use. And it was all built upon a leadership development approach to margin improvement. Our organization was siloed at best, and not because we didn't have wonderful people trying to do great things, but we had the burn center over here, Department of Surgery over here, our pediatrics over here, and unbelievable people, smart people with amazing gifts to bring to healthcare. But they never got out of their silos and shared those gifts amongst one another and come up with these wonderful ideas that could be rapidly implemented to produce change. I call those cylinders of excellence because they're wonderful, but they're part of a larger organization. And we had to all be pulling in the same direction. So at the end of the day, and by the way, I had suggestions as to how to approach our margin improvement. I remember some folks that saying, Steve, what you need to do is go over there to the governor's office and tell the story over there. Tell them that we're in trouble and what would happen to the state and to our population if an essential organization like ours went down the tubes. Horrible things that would happen. And so I said, well, hold on, let me get this straight. So I'll go over to the governor's office, and by the way, the governor ran on fiscal responsibility. He wanted every single one of his cabinet agencies to behave like a business and achieve benchmark levels of customer experience and so on. So I could imagine me going over to his office and, with the message, Governor, we're just not doing great, and we really need some help. And so here's the thing. If I didn't have a good story to tell in terms of supply chain, productivity, revenue cycle, quality metrics, and the like, if we weren't hitting benchmark levels of any of those metrics, then if I were the governor, I would say, Mr. Purves, I want you to get yourself back over to your health system and fix your own problem before you come to the state and ask for a bailout. Right? Now, we had things stacked against us because of our payer mix, and we rely a lot on Medicaid and supplemental funding and the like. But we had fat in our system, and we didn't take full advantage of the gifts that our wonderful people, and this is where the resiliency of the American healthcare workforce really came into play. I mean, it's amazing stories of nurses and techs and at all levels, physicians, working together to come up with wonderful ideas that we worked hard together to implement and to get rid of the slow no in an organization. You know what the slow no is? It's when somebody comes up with an idea and then a year later they don't hear anything. And they say, whatever happened to that idea? Oh, we decided not to do that. Employee would say, well, thank you so much for telling me. I could have stopped worrying about it, So we tried real hard, to do that. So we started a program that we coined 100-Day Workouts. And each one of these ideas, one of these topics, were institutional focus. It was an all-institution effort on each one of these topics within a 100-day cycle. And by the way, this is a subject of another presentation that I don't have time to go into. But the whole purpose of this was to get a handle on readiness for change. If there is no readiness for change in your organization, I really don't care if you have the best strategy and the best, operational implementation, it's not going to happen. Your people need to believe it, that this is necessary, and why it's important to sustain a vital public mission. And so we actually measured the capacity for change within our leadership structure. And the results of that was benchmarked against the top margin-producing hospitals in the nation using a database from the American College of Healthcare Executives. And we showed how we stacked up, and that validated the fact that we had a long way to go. And that created, more of a readiness for change. So as you can see, we actually had 18 100-day workouts, so that's 1,800 days. And the key metric for these teams that worked within these workouts was that each team needed to come up with 8 ideas in a 100-day period of time. Some of them could not be implemented, and some of them were actually hilarious, and some of them were just ridiculous. But guess what? We celebrated the heck out of those. We created fun because they took the time and the effort to think out of the box and come up with these ideas. But even if 10% of these hundreds of ideas came to fruition, that could result in millions of dollars. So that's the concept of multiple ideas and rapidly implementing them. Suspending the organizational structure. My leadership team, their sole purpose was to clear out the bureaucracy, clear out the obstacles, and to enable these ideas to live and breathe in the organization. And at the end of the day, when we tracked the results, we didn't track theoretical savings. We only tracked what our CFO could certify hitting the income statement, right? So if I had come up with an idea and it says, well, it's going to save, it's going to improve productivity, but if it didn't actually reduce FTEs or get labor cost out of the organization, we didn't count that. It may have been a good idea, but we didn't count that. So that was the concept in a word or two. So these were the results. This is the cash improvement over those years, and it was really rewarding to see that number go up rather than down, and far away from the zero, which would have been in danger of missing payroll. And it wasn't any one thing. It was lots of different things. It wasn't just one bolus of things that saved us, at all. And so if you look at the net income impact, on this, over a 4-year period, we tracked it was a cumulative improvement of $187 million, cumulative improvement in net income, over those years. So anyway, we had to get a handle on this because we could not break ground or start one project with the $935 million that was generously supported by the public, in which property owners are refunding the debt. We couldn't start that unless my board had a comfort level that we were not just solvent today, but viable long term. So as a result of that, we started getting some accolades. We're a public health care system. We share everything. We're open to the public. Our board meetings are open. That's good and bad. But we belong to the people here, and it is our role, to make sure that we share our successes. So this was just an article that the University of Arizona, their Eller College of Management, actually uses today, in their undergraduate program in management and case studies. And we were very, very proud of that. It chronicled the process that we used to do the financial turnaround. Things started happening, with us. I was sitting in my office one day, and my public information officer called and said, "Hey, Steve, did you know that we just got 100 top hospitals from IBM Watson?" I said, "No, why didn't anybody ever tell me anything?" And so, I honestly, and then I had somebody, a peer of mine in another hospital said, "Hey, Steve, congratulations." I said, what are you talking about? And so this was the Everest Award, which actually I was more proud of than other things like Leapfrog and things like that, because this actually measured rate of improvement year to year in a variety of different things, quality, financial performance, productivity, efficiency, and those types of things. And this is something you don't pay for, and you don't, it just happens. They use publicly available data, you don't submit anything to them. So I was proud of that. And of course, the article that we wrote about, our financial turnaround was the Dean Conley Award winner for the American College of Healthcare Executives. And this, I share this with you because it's relevant, because when we were reinventing our system, it was much more about just the financial turnaround or the bricks and mortar. It was about culture. It was about rebranding. It was about a new vision, for our healthcare system. And our vision was to be nationally recognized for transforming care to improve community health. And so we want to share lessons learned. There's nothing proprietary, very few things that are proprietary in terms of what we do. So we're an open book. So tell the story about the rebrand and the project, itself. And so we had fun with this. I'm a kind of a sports nut anyway, and so we use sports themes, a lot. And we would dress up in jerseys, and we would just have fun, and celebrate the successes that we had. This is a picture of the old hospital. It is built like a brick, what house, okay? It was planned in the 60s, an old government, model, for construction. And this sign that you see, welcome Valleywise Health, was actually covering, it was a temporary facade that actually covered up, when we announced our new name, it covered up the old county moniker that was up underneath it. Now, the message is complex because everybody refers to us, and still do, as county hospital. And we love that. We love all the good things about it. When our law enforcement officers, Phoenix Police Department, Phoenix firefighters, when you see written on their bulletproof vests, if found, take me to county. Because they know the care that they receive in our trauma centers. That's a rallying cry for our team. Again, it was sort of an inferiority complex that we've had for years and years back when we were part of the county and not funded appropriately, and always kind of felt like we've been beat down. We want the public hospital here, but we don't want them to be too good. Right? Because politically, you don't want public money competing with private hospitals, right? I get that. I'm not competing with a private hospital. I need to grow to serve vulnerable populations that are growing with the population growth here. And I need to grow because what two things do you need to maintain a wonderful clinical learning environment for your students? You need a growing number of interesting cases, and we have them. You need faculty support. So if we're not growing, we're taking a vital mission that we have that does more to improve quality of life for Arizonans. And that's our teaching program that brings more learners into the state to go out and serve underserved areas. It improves quality of life. If we're not growing, then guess what? We're dying. So I think we've kind of taken care, of that message. And so fortunately, that message has resonated and allowed us, when we started the project itself, we took an integrated program management approach to this. We didn't have in-house expertise. We were lucky to have a $10 million capital budget. And certainly we didn't do, a whole lot of, when we did have to do some construction or renovation or whatever, we had job order contracting and all those kinds of things. So we submit that we have public procurement rules that some of you might have, but it is a pain in the you know what. But again, it's part of the burden that we bear as a public institution. So we sent out an RFP. We had lots of interest, and so this was the team that was formed to run our integrated program management office, consisting of Vanner Construction, which is the program manager. They're like our owner's rep, only a little bit different. They project managed all the components of our integrated program management office. We had Blue Cottage, which was our logistics workflow specialist, because we're getting ready next week to move over 200 patients from one hospital to another on June the 13th, 13-hour period of time. Good thing the old hospital and the new hospital is right next to each other. Okay. And so Blue Cottage worked with us on all the logistics and workflow. And then we had Siegel and Gale, which helped us with our rebranding. And then we had land advisors that worked with us, on all the real estate issues, because we had, sell and buy land, with these new community health centers. And then we had Innova, which was the strategic planning, and they helped us model in terms of the growth of the population and where vulnerable patients lived, and help us quantify that so that we could locate facilities where they needed to be. This was our old mission statement at the top. Accurate? Yes. Could everybody remember it? No. Could I remember it? No. Was it inspirational? No. Our new mission is simple: provide exceptional care without exception, every patient, every time. That's it. And we build everything around that. It's concise, it's simple, and it seems to resonate with the people who devote their lives to serving others, to serve the sick, the suffering, and the dying. And I'm amazed and inspired every single time that we bring new employees into the organization, and I get to tell them about our health system. I ask them, why in the world have they chosen healthcare? I got to tell you, I'm inspired every single day, and I guess that's why I've done this for almost 45 years now. So that's what it's all about. So here's our new hospital. It is an amazing facility. It's like, it's our old hospital was, 250,000 square feet, something like that. This is 680-some thousand square feet. The nurses are just amazing. They're saying, well, are you going to supply us with rollerblades, so we can get from one end all to another? But it is a real testament to the hard work that all of our people, have worked hard to get to, and we're going to open that facility with patients next week. So we're proud of that. New community healthcare system, a lot more than just the hospital. This is our comprehensive health center, which is right next to the new hospital that we revamped, renovated. We have all of our specialty care, in there. And then we also have a new multi-specialty clinic out in Peoria. Beautiful facility, 126,000 square feet. And again, that's got primary care, but it's got diagnostics, it's got other specialties, out there. We have a dialysis center out there. We have pharmacy out there. Matter of fact, we have pharmacies in all of our community health centers to extend that access to care. This is the hospital that we purchased from Tenet Corporation that couldn't make a go of it, out there. And we acquired it for a very good price. But we put a lot of money into it to retrofit it for a behavioral health facility. And that added significantly to our behavioral health capacity, but we kept the emergency department open, out there. And of course, the last couple things I want to leave you with is that we have a core mission as a teaching hospital. And I always say that teaching is in our soul at Valleywise Health. And the reason why is because if you really think about how a health system improves quality of life, for the citizens in the state, certainly they do it, through clinical care and care of underserved populations and vulnerable populations, access to health care, working with community partners on social determinants of health, raising the quality of life for everyone. And frankly, I don't think hospitals get enough credit when states get together and they're talking about their economic development efforts and they're attracting, like in Arizona, we continue to just boom in terms of economic development, semiconductors. I mean, there's a multi-billion-dollar facility going up, right here in Phoenix. It's like they're going to employ well over 5,000 people right from the get-go. And they're going to need access to high-quality health care. But we don't get enough credit in health care, for what we add to quality of life in the state. So what happens when you recruit one physician into your service area? What metric do states use when they compare their competitiveness with other states in terms of their economic competitiveness? A really key metric. It's per capita income. Okay, states compare that number, all the time. So what happens when one physician comes in? What happens per capita income? What gets built all around a physician? Nurses, pharmacists, medical assistants, you name it. And it raises per capita income. That metric alone, just is a fact. But more important than that, this is how we stack up in Arizona. We don't stack up really well in terms of, rankings in the United States in number of physicians per 100,000 population and the like. Number of residents on duty per 100,000 population. All those kinds of things. So, as a major teaching hospital that, we've got in any given year, 300 or 400 residents, in and around our health system every year, we feel compelled to make sure that our clinical learning environment and what we're doing to attract learners into the state is what it needs to be to support quality of life in Arizona. So that led to the creation of a new model for medical education here. And we partnered with Creighton University, with Dignity Health, Common Spirit, here, St. Joseph's Medical Center, our faculty, which is the district medical group, and we formed this 501c3 organization to actually commit a clinical learning environment so that we could grow medical education, nursing education, allied health, in our state. Here is Creighton University that has a wonderful medical school in Omaha, Nebraska. Omaha's a mid-sized market, about 1 million people. Here's Arizona, Maricopa County, 4.5 million and growing, underserved in terms of health training programs, medical schools, you name it. So Creighton University couldn't grow because they didn't have enough clinical learning environment in Omaha, but they had more demand for their medical school than they could take. And so it fit together beautifully, where we committed clinical learning environment and Creighton University built a $120 million new medical school, health science campus here, that the goal of which is to add between now and 2025, 900 new learners in the state of Arizona. So the reinvention of Valleywise Health was more than just a financial turnaround. It was more than just a $1 billion construction program. It was more than just a rebrand, in terms of, moving from Maricopa Integrated Health System to Valleywise Health. It's about a lot of different things. And so it's a journey. We're not stopped. We've already planning in terms of what's next. What has thrown us for a loop and everybody for a loop was the pandemic. So we broke ground in the spring of 19. What happened January 20th of 2020? The first case of COVID in the United States. We built this hospital and our entire health system predominantly in the midst of a pandemic. We planned to open in October of last year. We slipped a little bit. You can imagine that we did slip, but we're opening next week. And the pandemic created all kinds of opportunities for us. So these are the lessons learned. Establish a readiness for change. There was a discipline to that. Understand our public role. We belong to everybody, and we're open, honest, and transparent. Stay focused on your key message. Don't get distracted. Have a bias to speed to implementation with a focus on leadership development. And today, I can't tell you how many Six Sigma black belts we have running around our organization. Strong program management oversight. That's actually key. You got to have the right experts with you. And then certainly, we in healthcare say this all the time, a passion for complexity and a high tolerance for ambiguity. That it was especially true within the pandemic because that threw us for a loop. So I'm going to leave you with that. That's my story, and I'm sticking to it. I'm happy if there's any time at all to answer any questions. Any questions out there?
Actually, we are just about out of time. So
Okay.
Thank you, Steve.
Thank you.